Hello there, my name is Nivian Sukirthan. I'm a recently graduated final year medical student from Barts. Today I'd like to cover a topic of Met 3B, particularly breast. I'd like to go through some knowledge on breast lumps, causes of breast pain, and breast cancer. Okay, and most of the information here is just basically from past medicine. So here are the learning objectives for what I'd like to cover today. So, lumps and bumps to start with. So the three main things initially to cover under the aberrations of normal development and involution of the breast are fibroadenoma, breast cysts, and duct ectasia. So initially fibroadenoma. So these are very, very common causes of lumps in young women since the breast is undergoing development up until the ages of around 25 years of age, and your lobular units are forming and stromal tissue is being put down in the breast tissue. And this can all result in fibroadenoma formation. As I said, it's common in the younger population of women, and they contribute to a vast proportion of the causes of palpable lesions in the breast. They present as a mobile mass, very mobile in fact, and they develop from a whole lobule. They don't tend to hurt at all, and there's any increased risk of malignancy. And some people like to refer to them as breast mice. There are three main types of fibroadenomas. We have the juvenile type, which is more common in adolescents, followed by the common type and the giant type, which tends to be 4 centimeters plus. In terms of how you'd manage them, if they're small, so below 3 centimeters, and if the patient is of young age, you can just watch and wait. However, if they were to be greater than 4 centimeters, you'd like to do a biopsy just to ensure that it's not a phyllodes tumour. Fibroadenomas also tend to increase in size during pregnancy and times of lactation. Some women may prefer to have fibroadenomas removed, maybe because of appearance, etc. And so they can be removed if necessary using a circumareolar incision, whereas smaller ones can just be removed using a mammotome incision. And if the fibroadenoma becomes too large, we can perform a mastectomy. Moving on now to breast cysts. So they contribute to around 15% of all breast lumps. Can occur in the perimenopausal age group. They tend to be soft, fluctuant, very smooth, solitary swellings, and can be well defined, hence they're discrete. But we need to make sure that there's no underlying mass suggesting malignancy. There is a small increased risk of breast cancer if the patient is younger. On a mammogram, they tend to have a halo appearance, but an ultrasound can confirm the fluid-like nature of the swelling. Treatment-wise, basically just aspirate them and make sure post-aspiration on examination that the cyst has been completely removed. However, if your cyst contains blood or it keeps on refilling, then you may need to do a biopsy or excision. And then now duct ectasia. So duct ectasia again is more common in the menopausal stages of women's health, and it occurs when the breast ducts shorten and enlarge, and it's quite close to the nipple area. It's seen in around 25% of normal female breast tissue. Can cause a discharge. There are different presentations of it. Some of them may be like a cheese/creamy colour. Some of them may be green. There may be nipple retraction as well. And the discharge may come from single or multiple ducts. And the multiple ducts tend to be in the older group. Some of the lumps may be tender in certain patients. If the duct ectasia were to rupture, in some patients it can cause plasma cell mastitis, which is basically just inflammation. No treatment is required, it's conservative. However, if the patient is troubled with excessive nipple discharge, you can treat them by basically removing the duct. in both young and old patients. Now, some other benign breast lesions which we don't need to know too much theory on. So sclerosing adenosis can present as breast lump or breast pain. It's important to distinguish this from carcinoma because the mammogram can present them both as quite similar actually. It can cause distortion of the distal lobular unit without hyperplasia. However, complex lesions may demonstrate this. It is indeed a disorder of involution of the breast. It doesn't confer any increased risk of cancer, and treatment-wise it's biopsy. An excision may or may not be required depending on circumstances. Moving on to epithelial hyperplasia. So this has a variable presentation. May just be lumpiness throughout the entirety of the breast, or may just be a single solitary lump, and it is defined as an increased cellularity of the terminal lobular unit. Some people may present with atypia, some may not. If there is atypia, there is an increased risk of malignancy. Therefore, if you don't have atypical features, no need to worry too much, conservative management will do. If, however, your patient does have atypical features, you may need to monitor them slightly closely and potentially refer for surgical resection. And finally on this slide, fat necrosis. So tends to be on a history of trauma, whether that be minor or major. It tends to happen in obese women with large breasts. Again, there is a mimic here to carcinoma, so therefore we must investigate it to exclude that differential diagnosis. The lump may increase in size initially with an inflammatory response. The lesion is firm and round and then may develop into a more hard and irregular lump, and you treat it basically much like many of the other pathologies seen here with a core biopsy, just to exclude the breast cancer. Moving on to now some other common breast disorders. Fibroadenosis, first of all. This is more common in the middle-aged group. Presentation is of a lumpy breast but may cause pain, and often symptoms are worse around the time of menstruation cycles. Ductal papilloma are local areas of epithelial proliferation in large mammary ducts. There are hyperplastic lesions, rather than malignant or pre-malignant. And the key here is it can present with blood-stained discharge. However, there isn't really an increased risk of cancer. Again, it can be confused with a malignant lump, so because they present like a mass. So treatment is microdocectomy. Breast abscess would present as a red, hot, tender, fluctuant lump. It's more common in lactating women, often due to Staph aureus infection. Treat it using antibiotics and ultrasound guided aspiration. If there is overlying skin necrosis, you may need to refer for surgical debridement for that. Lipomas and sebaceous cysts, pretty straightforward really. They develop around breast tissue. Lipomas are just benign tumours arising from adipose tissue. And finally, tuberculosis may present also in the breast, but it's rare in Western civilization, particularly. And diagnosis is based on biopsy culture as well as histology. Now, moving on to causes of breast pain. Periductal mastitis, first of all. So this presents at a younger age than duct ectasia, which it is often confused with. Periductal mastitis presents with inflammation, abscess, mammary duct fistula, and it's often very strongly associated with smoking. Treatment for it is abscess drainage as well as antibiotics. In terms of presentation, so how to differentiate between duct ectasia and periductal mastitis. Duct ectasia, as I've mentioned earlier, it's in older women, often around the menopause. There's this green/creamy cheese discharge with nipple retraction. Whereas periductal mastitis, more common in younger women, of whom most are smokers. And here there is often periareolar or subareolar infections, which may recur. Now, mastitis is a very common sort of cause of pain in breastfeeding women, particularly. Basically, if someone is coming in with mastitis, first thing to do is just encourage them to breastfeed. If, however, you think they're systemically unwell, fever, chills, etc., and you think they've got a cut on the nipple due to trauma, like a nipple fissure, and symptoms haven't improved after about half to a day of effective milk expression and removal, then you need to consider further management. And the antibiotic of choice is Fluclox, because the most common cause is Staph aureus. However, still continue to breastfeed and express milk during treatment. If, however, the colour of the milk starts to change, and the mum isn't happy with what she thinks that the infection is quite bad, and there's pus-like discharge coming out, be sure to discard that milk. If left untreated, the mastitis can develop into a breast abscess, which, as covered earlier, requires drainage. And now, final one for causes of breast pain is cyclical mastalgia. So this is a benign cause of breast pain in younger females, often associated with menstrual cycles. We're not really sure of the underlying etiology, but we need to examine the patient thoroughly, looking for cysts, etc. In terms of the management, it's usually conservative, really, just give them analgesia. Some sort of herbal related therapies like primrose oil, flaxseed oil haven't been recommended by NICE. If the pain hasn't responded to conservative management for 3 months or so, and it's affecting their quality of life, then you need to consider referral to secondary care. And within this, they may use hormonal treatments like bromocriptine or danazole. Danazole being a GnRH agonist, and bromocriptine related to dopamine, and these can be more effective, but they do have side effects. Moving on to causes of discharge now. Okay, so it can just be physiological during breastfeeding. It may be pathological, often due to galactorrhea. So it could be related to stress, emotion, certain medication like typical antipsychotics, metoclopramide, domperidone. Could be due to an endocrine pathology such as prolactinomas, acromegaly. Prolactinomas, you've got the micro and the macro types, with the micro being under a centimetre and macro being above a centimetre. And thinking about the neurological sort of manifestations of a tumour in the optic chiasm region can present with a bitemporal hemianopia. We've touched on mammary duct ectasia causing a nipple discharge already. Cancers can also cause nipple discharge, but they tend to be blood-stained with an underlying mass and lymphadenopathy. And finally, intraductal papilloma, common in younger patients with a blood-stained discharge. So how you'd assess someone? So you do a triple assessment, essentially. So you take a history and examination, you do imaging of some sorts. Ultrasound tends to be preferred in younger women because they have denser breast tissue. Mammogram in older women, and then do a biopsy. And then you'd manage them depending on what you find, using the triple assessment for that. Fine, now moving on to the majority of this presentation, which is breast cancer. The majority of breast cancers arise from lobular tissue and ductal tissue, particularly ductal tissue. And you can divide that further into those that stay around that area, so carcinoma in situ, or those that delve a bit deeper, i.e. they're invasive. So those are the 4 types: ductal carcinoma in situ, lobular carcinoma in situ, invasive ductal cancers, which are the most common type, and invasive lobular carcinomas. There are other types of breast cancer listed there, but I wouldn't worry too much about those. We've also got Paget's disease of the nipple, which I'll cover later on towards the end of this presentation, as well as inflammatory breast cancers, again, not very common, 1 in 10,000. So what are some of the risk factors for breast cancer? So BRCA1 and BRCA2 genes are quite highly linked to both breast and ovarian cancer. Having a first degree relative with breast cancer in the past. Not having children, so nulliparity. Older age for the first pregnancy, so that's a cause. Early menarche and late menopause, it's due to the prolonged action of estrogen on the breast tissue, which is very important in development of breast cancer. HRT therapy and combined oral contraceptive use has been linked to breast cancer. Past history of it, not breastfeeding, exposure to radiation, gene mutations like tumor suppressor genes, etc., obesity, and also previous surgery in the area can cause damage to breast tissue, etc. So why you'd refer someone? So if someone's coming to your clinic, GP clinic, with the following things. So 2-week wait for someone who's 30 years plus with an unexplained breast lump, whether they have pain or not, or if they're 50 plus with any of the symptoms such as discharge, nipple retraction, unilaterally requires referral. If they're not falling into these two categories, but you think there may be something going on and you're suspecting that the patient ought to be on a 2-week wait, certain groups which would fulfill these criteria would include those with skin changes that may suggest breast cancer, or those 30 years of age or more with an unexplained lump in the axilla, probably due to lymph node pathology. Then we'd think about referring as well. And then finally, non-urgent referral for those under 30 with an unexplained breast lump with or without pain. The likelihood is this is likely to be benign, probably something like a fibroadenoma. But we would like to refer, but unlikely to need a 2-week wait referral though. So just a brief overview before I split it up into the various subsections for breast cancer. So, as with many cancers, breast cancer is commoner in the older age group, of which invasive ductal carcinomas are the most common. The pathological assessment is basically a triple assessment, and when you do the biopsies, etc., you want to be looking at lymph nodes, sentinel lymph node biopsies, to have a look at to what extent the cancer has spread beyond the breast. Surgical treatment is the most common, and it's often either a wide local excision or mastectomy, and there's various reasons for that which I'll go on to in the next slide. And once you do the surgical procedure, you need to make sure there's a good cosmetic outcome for the patient. Fine. And you can always think about reconstruction of breast tissue, and there's various methods of doing that listed here. So, comparing mastectomy with a wide local excision. So there are various sort of indication as to why you'd go for a particular one. So a mastectomy is preferred if the tumour is multifocal, so it's in various sites, it's centrally located perhaps, it's a large lesion within a small breast, so you can't really salvage much breast tissue, so you may as well remove it if it's a large lesion within a small breast. If it's a ductal carcinoma in situ which is greater than 4 centimeters, or the patient may well prefer a mastectomy. A wide local excision is performed if it's a single tumour, it's peripherally located, it's a small lesion within a large breast, the ductal carcinoma in situ is less than 4 centimeters, and again, patient preference. And then I've just talked briefly here about central lesions being managed using breast conserving surgery if a cosmetic result which is acceptable to the patient can be obtained, but it's quite difficult in small breast tissues, unfortunately. And in terms of prognosis measures, the Nottingham Prognostic Index is what is used to assess patients' prognostic probabilities. So, I'm going to split the breast cancer management into those 5 subsections. So surgery is the main one, followed by radiotherapy, hormonal, biological, and chemo. So surgery we've already touched upon already, really, with the mastectomy and the wide local excision. So just about it in a bit more detail. So most patients, as I've said, are offered surgery if they are diagnosed with breast cancer. You don't want to be doing surgery in those who've got multiple comorbidities, they're frail, they're elderly with metastatic disease. It's unlikely to be that beneficial. Before doing surgery, it's of paramount importance to assess whether cancer has spread to the axillary lymph nodes. In those with no palpable axillary lymphadenopathy, you can do a pre-op axillary ultrasound scan. If this turns out to be positive, then you need to do a sentinel lymph node biopsy to assess how many of the nodes you think have been burdened with breast cancer. In patients with breast cancer who present with genuine palpable lymphadenopathy already, then you need to do an axillary node clearance. Unfortunately, this can result in sort of functional impairment to the arm as well as lymphedema. So just to stress there, if you don't have palpable lymphadenopathy, do an ultrasound first, have a look at the lymph nodes. If positive, then you need to do a sentinel node biopsy. In those who present with palpable lymphadenopathy from the start, then you just need to do a lymph node clearance, basically. Depending on the characteristics of the tumour, which we've covered earlier, some may have wide local excision, some may have a mastectomy. And as always, try for good cosmetic reconstruction if at all possible. Radiotherapy. So radiotherapy is recommended for those women who've had the WLE because having radiotherapy will reduce the risk of recurrence by around 2 in 3 cases. For women who've had a mastectomy, radiotherapy is offered for T3 to T4 tumours, or for those who've had 4+ positive axillary lymph nodes. Hormonal therapy is basically anti-estrogen therapies, and they can often be used as adjuvant methods if tumours are positive for particular hormone receptors. Tamoxifen is the most popular one. It's often used in both pre- and perimenopausal women. Those who are postmenopausal are often, and they have estrogen receptor positive breast cancer, are given aromatase inhibitors such as anastrozole, letrozole, and this is because aromatization accounts for estrogen conversion and production in postmenopausal women. So that's logic behind using aromatase inhibitors in postmenopausal as opposed to pre and peri, which we tend to use tamoxifen. However, there are side effects of both, which I'll come on to later. And in terms of biological therapies, we can think about one common one is trastuzumab, which is often used in those with Herceptin 2 positive breast cancers. However, trastuzumab is contraindicated in those with cardiac disease. And final treatment modality is chemotherapy. Can be used prior to surgery to downstage a lesion or post-surgery as well. Right, so just to touch briefly on those 2 hormonal therapies I mentioned, tamoxifen and the aromatase inhibitors. So first of all, tamoxifen, it's a SERM, so it's a selective estrogen receptor modulator, and acts as both an antagonist as well as a partial agonist of the estrogen receptor, and hence it's used in ER-positive breast cancers. Side effects include menstrual disturbances, hot flushes, so these are similar to menopausal-like symptoms, VTEs, endometrial cancer, as well as bone mass reduction in the form of osteoporosis. In the postmenopausal age group, as I've mentioned, we use aromatase inhibitors, namely anastrozole and letrozole, and they inhibit peripheral estrogen production, which is the major, and as I've said, aromatization is a major cause of estrogen production in the postmenopausal age group. Again, side effects, osteoporosis, so doing a DEXA scan to assess bone mineral density is recommended by NICE. Hot flushes, very similar to those in menopause, menopausal symptoms, arthralgia, myalgia, insomnia, again, very menopausal symptoms. Right, so now we're nearing the end of the presentation, so just to touch on screening. So screening used to be offered between the ages of 50 to 70, but now that's been extended 3 years either side of those cutoffs, so between the ages of 47 to 73, and mammograms are done 3 yearly. So there's a variety of sort of inclusion criteria for screening, which I've listed there. So for the familial breast cancer screening, is offered if the person concerned has one first or second degree relative diagnosed with breast cancer, and if they don't need to be referred. So if the patient coming to you only has one first or second degree relative diagnosed with breast cancer, they don't need to be referred. However, if they've got any of the sort of risk factors I've listed below in the family history, then they will need to be referred for screening. And then second sort of set to do with screening, so women who are at an increased risk of breast cancer due to family history can be offered screening from a younger age. The following patients need to be referred to the breast clinic for further assessment, and you can see those there. Okay, so final pathology to cover is Paget's disease of the nipple. So Paget's disease is an eczematoid change of the nipple, and it's associated with an underlying breast malignancy. It's not a very common cause of breast carcinoma, but it's something to be aware of. In half of these patients, these Paget's disease of the nipple patients, it's associated with an underlying mass, the majority of which will be an invasive carcinoma. 30% of those without a mass lesion will still have an underlying carcinoma, we just won't be able to find it. The remainder will just have a CIS. So the presentation of Paget's disease can often be confused with just an eczema of the nipple. So it's you need to differentiate between that. So in Paget's disease, it involves the nipple primarily and only later spreads to the areolar region, whereas the opposite occurs in eczema. So it starts with the areola and then moves its way onto the nipple. Diagnosis is via punch biopsy, mammogram, as well as ultrasound scan, and your treatment will depend on the underlying lesion. So that brings us on to the end of this presentation. So we've covered today a bit about causes of breast lumps and bumps, causes of breast pain, discharge, as well as going through breast cancer, some of the treatment for that, namely surgery. We've talked about risk factors for breast cancer, we've talked about screening, and finally we finished on Paget's disease of the nipple. So thank you very much for listening to the presentation. I hope that's been informative for you. Thanks for tuning in. Good luck with your revision, and I'm sure you'll do well in your exams. Thank you.